Hello everyone, it's a pleasure and an honor to present here at this unique webinar. And many thanks to Hinne and Wouter for organizing this webinar. My name is Marc Mureau, I'm plastic surgeon at the Erasmus MC in Rotterdam, the Netherlands, and mainly involved in oncology, oncologic reconstructions, and obviously there's also a lot of head and neck surgery involved there as well. We do about 120 free flap head and neck cases a year, and I think about between 30-40 pedicle flaps. So I was asked to talk about all the perioperative measures you could utilize to try to stay away from trouble. I've got no disclosures, I have to tell you, of course, and apart from that, I'm very proud to work at one of the coolest and largest academic centers in Europe. You see here, it's all being built brand new. Last May, we moved into this newly built hospital. And here you see the oncology wing. And at the 6th level here, you see there's the new theaters, like 25 theaters. And here is our staff tower, and we are sitting at the 22nd level. So we're very proud at our new hospital, and I thought I should share this with you. But I'm going to present on all things you can do to keep away from problems. I'm going over a bit of patient selection as well. I was asked to elaborate a bit more on the discussion whether or not to choose to anastomose 2 veins in case of free flaps. Antibiotic prophylaxis, perioperative fluid management. I think this is more or less an anesthetist topic, but I try to do my best. Whether or not it's wise to use vasoactive agents. Of course, body temperature of the patient, which is very important, as I will show you. Antithrombotic agents, and then I will come to the recommendations, which are more or less evidence-based, and that's what we're supposed to do, evidence-based surgery. So first, patient selection. I think I agree with my previous speakers that old age is not necessarily a contraindication. And yeah, talking about patient selection, patients with head and neck cancer usually are of older age and have polymorbid conditions. And there are also a lot of smokers amongst these patients. And so there's not much of a selection really. These patients, they attract head and neck cancer, and we are there to treat them. So is this a problem for our patients? Older age per se is not a problem. It's not a risk factor for flap failure and neither for surgical complications after major head and neck surgery. As you can see here in this graph, the blue bars are the head and neck cases, and the red bars the breast cases. But for now, we look at the blue bars. And you see flap success rates of, on average, 95%. And of course, there are quite some complications in this patient group, over 20% systemic complications and almost 30% surgical complications, but it's not related to age. But it is related to age, older age, in combination with comorbidity, as in an ASA classification of more or equal to 3. So then you see over 2 times chance for medical complications and almost 5 times increased risk of mortality after a surgery. So it's this specific population which is at risk, and we should also try to aim to take care of all the medical treatments around these major surgeries. And then finally, smoking. Smoking is not a risk factor for microsurgical complications, but as you all may know, it is a risk factor for wound healing problems and delayed wound healing at the recipient side as well as the donor side. So this brings us to flap selection. This is a retrospective series of our own institution, and we looked at about 5,500 head and neck cases. Here you see the typical flaps we've been performing the recent years. Radial flap leading together with the fibula flap, closely followed by the ALT flap and some other flaps for specific indications. And if we look at our series over the years, I have to admit that partial and, so these are the total numbers, and these are partial and total flap failures combined. You look at the incidence of this, these complications, and they stay about around 10% combined partial and total flap failure rate. So not really a learning curve in the sense that, of course, during all these years, the staff has been changing as well. And if we zoom a bit more into the complications, so we had about almost 5% partial flap losses and just over 6% total flap losses in the total series. So we were interested in, could we identify risk factors for this to happen so that we maybe can select patients or flaps or look at other things so we can stay away from this dreadful complication. So, and you see here, this is the results of a multivariable analysis. And you see here 4 risk factors, or actually 1 is a protecting factor. If you choose a radial forearm flap, at least in our series, we had a lesser chance, 80% lesser chance for partial flap failure. Obviously, because this is a very anatomically safe flap with almost always the same surgical anatomy, as opposed to, for example, the ALT flap. Pulmonary comorbidity is also a risk factor for partial flap failure, interestingly, almost 5 times increased risk of partial flap failure. And anastomosis to the lingual vein, but I'm not really sure because this is an odds ratio of 7. These were only 6 cases, of which 2 suffered from partial flap failure. And this is statistically significant, but I doubt whether this is clinically relevant, but we could discuss this later on. But I think what is relevant, what came out of this analysis as well, is anastomosis to the superficial temporal artery, which also had an increased risk of total flap failure, usually because these vessels tend to be quite small, can be spastic. And I think to stay away from trouble, you should really dissect it down into the product gland, where the vessels become larger and have a better flow. So now to the discussion of is it necessary to connect 2 veins, because I know there's always a lot of discussion on this topic. And interestingly, literature is not really helping us here, because this is an interesting study by the people from MD Anderson. They did I think this is one of the only physiological studies they performed. They looked at blood flow, blood velocity, I have to say, in the arteries and veins of free flaps prior and after microsurgical anastomosis. And they saw a few things. First, there was also a significant increase in arterial as well as venous peak blood velocities after transferring of a free flap. And this is due to different reasons. You have to think of post-ischemia, hyperperfusion because of vasodilation, and also denervation of the parasympathetic and sympathetic system around the vessels, which also gives dilation of the vessels. But interestingly, if you zoom into the single vein free flaps versus the double vein free flaps, they discovered that flow was significantly higher in the single vein free flaps, in the vein that is, as opposed to either veins of the double vein free flaps. So you can see these velocities are much higher, sometimes 3 times as high as in the double vein free flaps. And also, if they had a double vein free flap, and they, after transfer of the flap, they clamped one of the 2 veins, they saw that the flow in the other vein increased. So to conclude, single vein free flaps have a higher blood velocity in this single vein compared to double vein free flaps. So theoretically, then you could conclude that double vein free flaps are more prone to thrombosis, venous thrombosis. But that's not what the clinical literature is telling us. These are 3 papers on this topic, and these were all retrospective case series of the respective institutions. And the largest problem with these series is that it's not randomized series. So it was at the discretion of the surgeon either or not to connect 2 veins. And I think this brings a lot of bias into these studies. But yeah, most of these studies, they show that at least if you connect 2 veins, chance of having to re-explore your flap is less. So you can see this clearly here in this table, that the single vein free flaps have a higher chance of venous congestion as opposed to the double vein free flaps. But interestingly, didn't lead to more flap losses. And this is another study which also showed that in the single vein free flaps, the need for re-exploration was higher, and in about 1/3 of all these re-explorations, it was due to venous congestion, and sometimes it was a hematoma or other reasons, and only like 5.5% in the double vein group. And this is the single one study I could find which also showed that 2 vein free flaps also had a lesser chance of having a flap failure, a total flap failure. So this is, in conclusion, only one study showing that the use of 2 veins leads to a lesser chance of flap failure. But all these studies have bias by indication. And I think we really need a prospective study with randomization in choosing 1 or 2 veins. But in conclusion, I try to summarize some arguments against and in favor of the use of 2 veins. And I really think it's per indication when you're in doubt which venous system is dominant, for example, in a radioform flap, or you have, after connecting 1 vein, you have obvious congestion of your flap. I think these are really hard indications for a double vein. And I think these things I'm not really sure about, because this is not the experience we have at our institution. We have about 6% re-exploration in our series, and this is comparable with the 2 vein exploration rate in these other series. So I'm not really sure. So still some research work to do for us here. Okay, antibiotics. I think this is an interesting meta-analysis which showed, because you can see here 4 forest plots showing that if you give antibiotics for a prolonged time, so that is more than 24 hours or more than 48 hours, there was a decreased chance of recipient site infections. But they did a post hoc analysis with multivariable correction for confounding factors, and they, after this correction, they couldn't really find a significant difference between the shorter duration of antibiotics, that is a maximum 24 hours, and the longer. And interestingly, they also found that clindamycin is not a very good choice for antibiotics, because interestingly, there was an increased risk of recipient side infections with an odds ratio of almost 3. So they concluded from their meta-analysis that you shouldn't use clindamycin if you're going to use antibiotic prophylaxis. If you choose the right antibiotics, then a 24-hour prophylaxis should be sufficient. And there's the American guideline of hospital pharmacists stating that these are the antibiotics of first choice. And actually, these are also the antibiotics we are using in daily practice at our institution. That is 500 milligrams metronidazole in combination with cefazolin, 1 gram. And we only give them in between 60 and 50 minutes prior to theater. And we don't give post-op antibiotics as a standard of care. So I think this brings me to the most complicated or complex topics of my presentation. That is the how to manage fluid replacement in these prolonged surgeries in these usually frail patients. And I think the objective of anesthesia should be to have adequate tissue oxygenation through adequate cardiac output, and that is not the same as a good blood pressure. I think it's important to realize this. Also a bit of physiology, back to medical school. So if you want to achieve this, then, and you look at the Frank-Starling law or curve, one way to achieve this is to strive for a hyperdynamic circulation, because then you see at the y-axis your stroke volume increases. But you shouldn't do this by aggressively replacing fluids. And I think this is an old microsurgical dogma that you're not allowed to use vasoactive agents. We will come to this later. And then only are left with filling these patients aggressively. But we know now from a lot of literature that this leads to primarily to the damage of the glycocalyx layer, that is glycoproteins and lipids around the cells of the blood vessels, and this causes extravasation and edema, and this will cause increased counter pressure of the tissues and the vessels, and this will cause reduction of your blood flow and stasis and thrombosis. And this is, so we know now that this will lead to a higher chance of flap failure, but also to a higher chance of medical complications due to edema, like, for example, cardiac decompensation. So we should strive for hyperdynamic circulation, but not by aggressive fluid replacement. So no hypervolemic situation, but a normovolemic hemodilution. That's the preferred strategy we should follow, so, which is also beneficial for the patient as well as our flap surgery. And we should aim for hemodilution because blood viscosity plays a role in flow. As you can see here, you see precise law, and viscosity is inversely related to flow of through a tube. And also, it's related to the hematocrit. Water has a relative viscosity of 1, and blood almost the same if you strive for a hematocrit of about 30 to 40%, because if you go lower, then of course the oxygen transportation of the blood decreases, but the viscosity doesn't decrease anymore. So this is the optimum window for your hematocrit to strive for. And we strive for normovolemic, as I already told you, because then you will not end up with edema because of your glycocalyx impairment. And edema will eventually, if it becomes bad enough, it will lead to stasis and thrombosis. But it also, if you have a normal volemic circulation, you have less need for blood transfusion, which also can give some complications. It has a decreased risk of dilution coagulopathy and a decreased risk of medical complications, such as for, I think this is a very important one to try to avoid, is the cardiac decompensation, because then also not only the patient's life is at risk, but also your flap. And that I think we should all try to prevent. So to wrap this up, we aim to have an optimal fluid replacement, but the rate, that's then the other question. So normal volemic hemodilution, but then what is then the optimal rate? And there's been some literature around. This is from a group from Toronto, and they looked this up for microvascular breast reconstructions, but they were able to show a parabolic relationship between the fluid replacement rate and chance of complications. So if you are not giving enough fluid replacement, you get more chance of complications. And if you're giving too much, obviously, you also will get an increased chance of complications. So from their study and some other studies in head and neck patients, which this is also a nice one from Toronto, they came out that you shouldn't exceed 6 mils per kilogram per hour. And in total, you shouldn't exceed 7 liters of intraoperative fluid replacement. Because we know then that if you are ending up in this group, you will end up with more systemic as well as surgical complications. Crystalloids or colloids, there's still no consensus on type and regimen, what to use. There's very limited literature on this topic related to microsurgery, and they all have side effects and disadvantages, but also advantages. So basically, it's not either crystalloids or colloids, but usually most anesthetists will end up with a combination of the two. Another strategy to get a sufficient cardiac output is not only to have a normal volemic hemodilution, but also to use vasoactive agents, which still is surrounded by controversy, especially in the field of reconstructive microsurgery. But you can use these agents to increase the perfusion of your flap. These are the three most used agents, and they have a bit of a different mode of action, but the more beneficial ones are actually norepinephrine and dovitamin, because they increase as well the flow of the flap as well as cardiac output. And more importantly, if you look at evidence in literature, there is no clinical evidence against the selective use of systemic vasoactive agents during free flap surgery. Here you see again two forest plots of meta-analysis, and looking at the use of vasopressors and the chance of flap failure rate or flap complications, and basically there's no such relationship. And there's even some literature suggesting that dovitamin could even increase the perfusion through your free flap. So if you're looking at the more modern literature on this topic, you will end up finding this new, I think for me it was a new term, goal-directed hemodynamic therapy. And this is this management of all the vital functions of the patients And the goal is to have a good cardiac output with a variation in stroke volume less than 13%, 13%, that is. And you can do this with fluid management in combination with vasoactive agents and maybe some other treatments as well. But this should be the goal. And dogmas like you shouldn't use phenylephrine, or you shouldn't use this, or that's all obsolete to my mind, because there's enough evidence now around that it's perfectly safe to use these agents. Even there is some literature showing that if you do this correctly, it's even beneficial for your patients. So it will lead to less complication, and this is then shown here as in a shorter ICU stay. And this is another study showing basically the same, but also with a decreased chance of flap failure, and that's what we're all aiming for. So your anesthetist can even help you to improve your surgical outcome. So I think this is a very important take-home message to discuss with your team at home, and go for this goal-directed hemodynamic therapy. I think it really can decrease complications and improve your results. This may be another thing which is you can also put under this umbrella of goal-directed therapy. Maybe not hemodynamic, or maybe it is, because if you have hypothermia, you also get, of course, vasoconstriction. And I think it's known from multiple studies from different kinds of surgical patients that hypothermia is detrimental for your patient in the sense that it is increased with, associated with increased risk of infections, and also some cardiac problems. And if you have a serious hypothermia, that is core body temperature below 35 degrees, it's also associated with increased risk of flap loss, which is shown in this graph here, that if the temperature is, the mean intraoperative core temperature is dropping, if you go to the left here, you see an increased risk of recipient side infection. And you see also here that in the lower temperature group, the percentage of infections was much higher than in the higher temperature group. So also important, temperature management during and after surgery. I think this is one of the latest slides, basically summarizing what has been around for antithrombotic agents from a survey which was done under American microsurgeons. It's known that almost 100% uses some sort of antithrombotic therapy to hope to prevent thrombosis postoperatively and to get your flap failure rates down. But there is still no consensus on ideal agent, timing, and dosage. And what's around, unfractionated heparin, low molecular weight heparin, aspirin, and dextrins. From dextrins, we know from the study by the group from New York, I think it's almost over 10 years old, this study, but it was a prospective study showing that there's no beneficial effect of dextrins. If you look at flap survival, but it was associated with serious systemic complication as pulmonary complications and myocardial infarction. So the use of dextrins to try to prevent thrombosis is obsolete. I think you should not do this. This is not a good idea. Then intraoperative use of unfractionated heparin. There is some evidence that it may be beneficial to give a bolus of 5,000 units just prior to your anastomosis. as for the intraoperative patency rates, but no true effect on flap survival rates. And if you are going to use it systemically, also postoperatively, like in a drip, it may even increase the risk of bleeding. And then you also have to bring your patient back to theater, so that's also not a good idea. Aspirin, we all know, especially when you give it for a prolonged time, it causes an increased risk of gastrointestinal bleeding, but there's never been shown a true beneficial effect on flap survival. This brings me to low molecular weight heparins, which are being used in the Netherlands as standard of care to prevent systemic thromboembolic events like deep venous thrombosis or pulmonary embolisms. So every surgical patient in the Netherlands receives low molecular weight heparin as standard of care. And this may also have an effect on your microsurgical anastomosis, at least to the same extent as aspirin does, but it doesn't have the side effects of aspirin, and it also does not have an increased risk of post-operative bleeding. So if you want to use some sort of antithrombotic agent, I think you stick to low molecular weight heparin because also of the additional beneficial effect of preventing pulmonary embolism and venous thrombosis. So this is the last slide, trying to wrap up all the information I've been transferring to you. And I can imagine the presentation went a bit fast and there's a lot of information, but you can, I think, all read it back on the Icoplast website. But we should strive for normal volemic hemodilution and don't overfill our patients, because that's bad for them and also for your flap. And you can use your vasopressors when indicated to treat hypertension and to improve cardiac output and flow through your flaps. To venous anastomosis, I don't think that there's a need for a standard use of this, but on indication. But all patients should receive antibiotic prophylaxis for 24 hours. If we believe our publications, and we should of course make sure that the patient does not get hypothermia. And I think for antithrombotic agents, there's no place for all these agents I've been discussing apart from low molecular weight heparin. And I will leave it here, and I will give Hine back the mic, and thank you very much again for letting me speak here.
Yeah. Thanks, Marc. Again, impressive all the literature you've been plowing through and to order it up so nicely. Maybe as a start, it's good to share the results of the poll that we did. If I can get it to run, yeah, it's there. So my perioperative protocol, most 63% use inotropics, that's fine by them. Anticoagulant protocol, 63% use routinely heparin to prevent anastomotic clotting up. Aspirin, 63% don't use them. Dextrans, 80% almost doesn't use them. IV fluids, most of them participants titrated to the urinary output. Head positions, which is not our point of discussion with some of the people that they registered. Prior to finalizing the procedure, most of us check if it's okay, and if it is okay, no restrictions are met. And drains, 70% use drains on vacuum, 26 use them non-vacuum, and some use them sometimes, but everybody uses them. I think, Wouter, we have two questions, one from our own Eastern Europe maxillofacial surgeon, Barry Kolinar, but please.
Yeah, and one question from Nathalie Roche. First question was that question for Marc Mureau. Do you think that the recipient vein has any effect on venous thrombosis or not? Was this studied in the paper you discussed?
No, this was not discussed in the paper I presented, but I know some papers have been published on this topic. That is the difference between the internal jugular vein or the external jugular vein. I think most head and neck reconstructive surgeons go to some side branch or side to end to the internal jugular vein, because it's been shown that this has a decreased risk of thrombosis as compared to the external jugular vein. But sometimes the internal jugular vein has been resected because of local tumor invasion. And then I wouldn't hesitate to connect to the external jugular, and we've done this on many occasions without problems. But we also, I can think of 2 cases which had a thrombosis of the external jugular when we had connected our free flap to this vein. So you should think of this, but sometimes you don't have a choice, and then you still hook it up to this vein, and yeah, you have a slight increased risk of problems.
Yeah.
Ed, what is your practice? Do you have a favorite venous acceptor vein?
Generally speaking, we do favor the internal jugular if there is a branch. Oftentimes in the kind of frozen neck where patients have had previous surgery, previous radiation, the internal jugular vein may not be accessible. Alternatively, you can always go end to side into the internal jugular, but ideally if there's a branch to go end to end, that's generally our preferred preference. However, we did do a study, it's not published yet, but we did compare outcomes between using the external versus the internal, and it didn't seem like there was a difference in flap success rates or complications. So we will routinely use the external jugular if it's available.
The external or the internal?
The external. Yeah.
External.
So, yeah, when we compared our experience, the data's not published yet, but it did not seem to be a risk factor for having flap loss or issues with congestion. The thing is, though, is that you do have to be careful because it is subject to compression. So external compression, either from dressings, from trach ties, things of that nature, can compress the external jugular. So when we use external jugular, we always make certain to communicate that with the nursing staff and everyone to make certain that there aren't any tight ties or any type of compression on the skin and the vein.
Samad and Jonathan, do you have any preference?
We would tend to go end to side onto the IJV. That's the kind of the more common practice for us. And we'll quite often do a coupled anastomosis. We'll use a venous coupling device. But it just feels to us like the flow through the IJV is almost drawing blood out of the flap when you watch it sort of happening. But likewise, if the IJV wasn't available, I don't think we'd have a hesitation to go to the external or the transverse cervicals or any of the other options we've got. But the IJV will be our first choice. One of the, I suppose, slight concerns I'd have with the external is depending on the state it's in by the time we get up to the neck as well, as to what the resective surgeon has done with it before we've got there. Whereas the IJV is normally relatively unscathed.
I think I've personally changed my practice, but when I was working in Pakistan with the specific head and neck surgeons who I was comfortable that they are going to preserve the external jugular for me, I would go for external jugular as a primary option. But if I'm not sure whether the external jugular is going to be preserved or not, if there is any risk that it might be damaged during neck flap elevation, then I would preferably go to IJV. And as Jonathan said, that here our go-to vessel is IJV, either directly onto it or taking one of the side branches using a coupled end-to-side anastomosis. Yeah.
So how about these couplers? What is your thoughts on coupler devices in head and neck reconstruction for the venous anastomosis? Does it make a difference when there is a difference in diameters between acceptor and recipient and flap vein? What are your thoughts on that?
When when I did my fellowship before starting here, we did probably 80, 90 flaps in that, or I was involved in 80, 90 flaps in that year, and we didn't use a coupling device at all. And when I came to Nottingham, it was something that Sarmide had been using, and so I started using it as well. And I have to say, it's been great. I think when you've got difference in vessel diameter, it copes with that very, very well. It seems to maintain the patency of the anastomosis really nicely, because it's physically holding it open. One of the big things is if you've had a prolonged flap inset, which sometimes with a complex low pharyngeal inset, it can take you some time to inset the flap before you're fully plumbing everything in. You know, doing a coupled anastomosis is very fast. And one of the things I've done on a couple of occasions, I've put the coupler in as onto a side branch of the IJV or inside onto the IJV, and then our trainee can do the second anastomosis, knowing that I've got one that's running well, that's taken me 5 minutes to do, and we've then got the flap running fine, and the second vena comitans can be plumbed in by the trainee as a hand-sewn anastomosis to make sure that we're keeping the skill set maintained.
No, I think that is something
Adam, Mark?
For the neck surgery, we are not routinely using venous coupler devices. We do for breast surgery. And I agree with the other speakers, the advantages of the couplers. Of course, it's much faster, especially in large veins, because then you have a lot of stitches to do. But on the other hand, I think the vein in the neck to anastomosis, it's perfect for training issues, because usually it's very large veins, and it's good for residents to learn microsurgery.
Yeah. Ed, what are your thoughts? I know MD Anderson did a large series on it.
Yeah, we typically do use the venous coupler. Very few people hand sew the anastomosis now. But we did look at this, as you said, and it seemed that the venous coupler had lower complication rates than the hand-sewn anastomoses, and it did turn out to be a significant difference. But it may be, again, it was a retrospective study, so there may be bias as far as what the rationale was for why the anastomosis was hand-sewn. It could have been that the coupler could not be used. It was a more difficult situation, again, because in a previously radiated neck, if you're going, say, for example, end to side into the internal jugular, doing a couple that's going to be more difficult. So you're probably going to hand sew that anastomosis. So there may be some bias, but in kind of the analysis, we did find that the coupler was beneficial and had lower complication rates.
And there's is there a certain diameter you want to stay above or below, or it doesn't matter?
We did do this study recently also, and it showed that a coupler size or less than 2 millimeters had an increased risk of complications. So in general, if you can get a vessel that's more than 2 millimeters, that's the ideal circumstance. That may not necessarily be applicable to a relatively small flap. Sometimes the forearm vena comitans are only 1.5 millimeters, but generally speaking, probably less than 2 millimeters on the coupler has an increased risk of complications.
There's a few more questions.
Maybe it's a good idea if we continue to Andrew Norris, while Marc Mureau, maybe you can answer the 4 questions in the Q&A department. They're specific for your talk, and then we can continue.
So the first is from Barry Kolinar. Did you see any, I didn't see any DCIA in Rotterdam. Is there a reason, or is it not included in your analysis? Question from Mark. I'm muting.
Hello, can you hear me?
Yeah.
Okay. Now, we don't like this flap because of its donor side issues. So if the fibula is not available, our preferred second bone flap would be the lateral edge of the scapula. And then a question from Bulgaria, Stancho Prodanov. Hi, Stancho. Normally, how long do you give low molecular weight heparins post-operatively, and maybe also what's the dose you would typically use? until the patient is discharged. So that's standard of care for every surgical patient in the Netherlands, not related to microsurgery. So the thought behind it, if you're fit for discharge, you're mobile enough to be able to stop your low molecular weight heparin. But if you should have indication to still proceed with it, patient can inject it subcutaneously themselves at home. Yes, and it depends on which low molecular weight heparin you use. But I think normal dosage is 3,750 international units, and maybe in high-risk patients or in our deep flap patients, we do a double dose.
Ed and Jonathan, can you briefly comment on your LM, low molecular weight heparin use?
We only give routinely Lovenox daily, really for DVT prophylaxis. No one routinely gives anticoagulation for prevention of flap thrombosis, but people stay on the Lovenox starting postoperative day 1 until discharge. Yeah.
Barry has another question. What about no postoperative antibiotics? And I'm not sure, Barry, if this is what you mean, but do you use, so basically, Marc, you use antibiotics for 24 hours in all flaps?
No, we only do one shot preoperatively.
Okay, so no.
I asked our head and neck surgeons today because I wasn't sure. Because in our deep flap patients, we do intraoperatively every 4 hours because you also have some blood loss and you can also lose some antibiotics through blood loss, and also because it's sometimes prolonged procedure. Yeah, the half time of the antibiotic is passed, so then you don't have a proper concentration in your blood anymore. So I think maybe it's on the conservative side to only do it preoperatively, and if you look at the literature, the recommendation is to do it for 24 hours, and that should be enough. Also to prevent multi-resistance issues, and I think a lot of countries in the world have these problems.
Talking about other countries, Samad and Ed, what is your antibiotic use?
Please, Ed, you go on.
For any patient that has an intraoral defect or there's kind of a communication to the neck, we usually give people Unison pre-op, and we maintain them on Unison until discharge. There's no real data to support the benefit of that. It's mostly kind of voodoo practice to minimize the risk of kind of an infection in the neck. But again, there's no data to support that practice. For external defects, scalp, parotid, or defects that don't involve the oral cavity or the oral pharynx, those patients usually just get the 24-hour dose of antibiotics.
So much?
So we would normally follow whatever our head and neck surgeons protocols is. We don't specifically ask for a specific antibiotics, but it is normally we do repeat a second dose within the surgery if the surgery has gone for a longer period of time, and then we continue it for once the patient is in ITU for up to 24 hours. But after that, we don't tend to continue the antibiotics for a longer period of time, and we tend to stop them as soon as possible.